morning, everybody. Good afternoon, good evening, good night, depending on where you are joining us from. So welcome everybody in person and online to our first hybrid International Health Workforce Collaborative meeting hosted by the Canadian Health Workforce Network. I was just going through the statistics last night, and we have over 360 registrants, 17 from Australia, 1 from the Bahamas, 2 from Belgium, 1 from Burundi, 260 or so from Canada, 1 from France, 1 from Hong Kong, 1 from Iran, 3 joining us from Malaysia, 1 from Mexico, who's actually a Canadian who's displaced in Mexico. Hello. 4 from Poland, 1 from Portugal, 5 from Switzerland, 2 from the UK, 21 from the United Kingdom, and 30 from the United States. So welcome everybody. My name is Ivy Bourgeau, and I'm very pleased to be leading with a bunch of amazing folks, the Canadian Health Workforce Network. We're coming to you live from the University of Ottawa, situated on unceded, unsurrendered Algonquin Anishinaabe territory. And I bring greetings from Elder Jenny Tanasco from Kitigan Zibi, who is not able to join us today, who lost her voice. But she typically provides a really lovely welcome. And so I just wanted to acknowledge that. For those of you who are new to the International Health Workforce Collaborative meeting, it is a collection. It is international in the sense that it's typically Canada, US, UK, Australia, often New Zealand. And this group has been meeting since 1996, originally as the International Medical Workforce Collaborative. And somewhere in between early 2000, it was changed to the International Health Workforce Collaborative. You may be wondering why we are doing an event in December in Ottawa. And that's in part because we have funds. And so want to acknowledge funds that are going to run out in a certain amount of time. So we want to thank our sponsors, the Employment and Social Development Canada funded Team Primary Care Initiative. And there will be a session tomorrow afternoon, quite specifically on that. And also from our Canadian Institute for Health Research funded Minimum Data Standard Project. And Catherine will be presenting that in our second panel. So I'm now going to pass along to a tradition that we have at the International Health Workforce Collaborative is just to do country dispatches, sort of what's the latest and greatest that has been happening in each of the IHWC countries. And I'm going to pass to our moderator, Steve Slade, who will moderate the panel. Welcome, Steve.
Hello. Hi, thanks, Ivy. Welcome everybody in person. Welcome everybody online. We can't see you, but we know that you are there in numbers. Great. I want to welcome our panelists to start out here. I'm Steve Slade. I'm the Director of Research at the College of Family Physicians of Canada and was happy to have this opportunity to moderate this opening session. As Ivy said, you know, we used to have these great sort of roundtable country catch-ups, what's going on, and we're happy to keep that going here. One of our panelists, this being Canada, you know, was driving in today, had problems with the car, and has circled back and is trying to join us online. I'm not seeing Marilee there right now, but we'll soldier on as it is. I want everyone to know as well, we're going to open up here with some quick 10-minute rounds from each one of the speakers. We want to get, you know, have you hear from experts within their countries just to get a bit of a lay of the land. So we'll take about 10 minutes per speaker. And that will use about half of our session. And we do want to have a very open, you know, discussion. We want that opportunity to be there. So at the end of the 10-minute intros from each of the speakers, I'm going to ask for if there's any questions of clarification, not really to get into the issues that they will surface. There's going to be many of them. But if there's a question of clarification, what does that acronym mean? Or, you know, what does this or that mean? Please feel free to ask those questions. We'll take maybe a minute between the speakers, just a minute or two between the opening remarks, just to do questions of clarification, and then it'll be wide open. I cannot see the chat. I want you to know that online. You're probably you may be putting questions into the chat right now, and I can't see them. I will do a shout out to our booth here. during the meeting, and then Sheena will be able to read out your questions if there are questions coming online, but also we'll welcome the speakers to talk back and forth and so on. So without further ado, I would like to introduce our first speaker, Alison Leary, who's Chair of Healthcare and Workforce Modeling, London South Bank University. So Alison, please feel free to jump in.
Thank you very much. Thanks, Stephen, and thanks, Ivy. Lovely to be here. Thank you so much for the invitation. I'm just going to share my screen, so hopefully you can see that. Yes, and I'm based in London, but we work across the UK, and I work across a number of different industries, including healthcare. So I've probably a different perspective than maybe many of our policymakers. We specifically research the interface between workforce and safety in a number of different industries. And I thought we'd just do a bit of an introduction. If you're not familiar with the UK's health system, we are 4 countries and many employers. I quite often meet people that think we have one employer, which is our nationalised health service, but actually that's not the case. The NHS is made up of lots of different organisations. For the last 10 years, it's actually been more of a free market competitive labour economy. So each organisation, each hospital has a foundation status, and it can recruit, although there are agreed pay and condition scales, they're actually different employers now. So the NHS is more of a brand than it is actually an organisation in England. In the other 3 countries, it's more of a central employer. It's still the biggest employer. The NHS employs around 50% of registered nurses in the UK, and health and social care is a major employer generally in the UK. So around 1% of our population is actually on the nursing midwifery register. So a lot of our population are registered nurses, and if you take that up to, it's around 5% of our population generally work in the sector. So it's quite a hefty chunk of the population, but we are increasingly reliant on a global workforce and on the international labour market. And that includes actively recruiting from WHO Red List countries. So around 20% of our current registered workforce did not train in the UK. They are people that have come to the UK. And this is causing some issues in terms of the ethics of recruitment. So some of our current issues, we actually have quite a lot of vacancies. We have 109,000 vacancies in the English NHS alone. 50,000 of those, just short of 50,000, are registered nurse vacancies. In social care, so we have a system that is health and social care, which are meant to be joined, but are quite separate in reality, apart from in Northern Ireland, where they are integrated. We have 170,000 vacancies in social care. So you can see we've actually got quite a high deficit in terms of our labour provision. And we've got lots of confounding issues too. So Brexit was a really big factor in social care, particularly, but also in healthcare. We had a relatively large population of people from Eastern Europe working in the UK who seem to migrate back after Brexit and of course haven't subsequently come to the UK. We have pay restraint, that the worth of an NHS paycheck is going down fairly considerably, and because most employers agree to the NHS terms and conditions, that means pay across the sector is suppressed. That makes it unattractive. And subsequently, we've seen industrial action. We saw last year the Royal College of Nursing, for the first time in its 106-year history, take its members out on strike. We're facing a junior doctors strike, so a doctors in training strike in January, the longest NHS clinical strike in history. We have financial models that encourage so we've been subjected to a policy of austerity for the last 10, 12 years, and a financial model that really encourages a low-paid workforce. So most hands for least money kind of workforce, what we might think of as the Christmas tree model. What we've also seen is the introduction of multiple new roles. So I scrape job titles because I'm a nerd. And currently in the English NHS, we have 77,000 different job titles in my data set alone, which is very confusing for people. We've seen the taskification of care. So as the skill set has diminished, particularly specialist and expert skill, what we've seen in response to that in terms of safety is to taskify care. So to have a more tick box approach to delivering care, and care is a series of tasks. We've seen issues due to the pandemic, particularly moral distress. And there are quite a lot of papers on that actually coming from the UK about the moral distress and the exhaustion that the remaining workforce is facing. We're seeing a lack of development and succession planning. So what we're seeing is less investment in, less national investment in continuing professional development. And for the first time, work-life balance has overtaken retirement as the principal reasons for leaving in our national data set. It's also a pink collar workforce, which obviously doesn't help with the pay restraint issue. The healthcare workforce in the UK of people in NHS employment is 77% female and 89% female in nursing. We see not only the glass escalator, so men being advantaged in a predominantly female workforce, but we also see the sticky floor in action. So women working part-time and women from global majority populations really being pulled back in terms of pay and progression. And very much a reflection of the World Health Organization report on women delivering and men leading, in fact. And we also have some fairly substantial issues around issues like racism and bullying in our workforce. So in London, for example, over half of the workforce is from the global majority. And in terms of our national staff experience survey, we see a lot of these issues cropping up fairly regularly and at a fairly significant rate. And we have employers that are trying to respond to that, but it's really, really quite a substantial issue that employers are facing in that regard. So this is an example of the sort of deprofessionalisation that we're seeing. So in the UK, we have community nursing, quite often called district nursing. It's been around for 140 years. It was actually the Queen's Nursing Institute, which trains these nurses, was actually founded by William Rathbone and Florence Nightingale. So it's been around for a long time. And contrary to my students, I believe, I didn't know Florence Nightingale. But what we can see here is we've got three groups of workers. So we've got the registered nurse at the top, and we've got the support workforce, there's a CNA type workforce in the middle. And then at the bottom, we've got people with the specialist practice qualification. So the certification to work in that environment. And as you can see, we've seen quite a big downdrift in that specialist practice qualification holding workforce, and an uplift in the people without it. So even though we're not losing registered nurses in that sense, what we are losing is the people with the specialist practice qualifications. And we see this in many of the specialist areas, such as areas like mental health, learning disability and autism, health visiting, you know, the people looking after newborns. So we're seeing that generally, a kind of deprofessionalisation that's working across the workforce. We're also seeing some really interesting issues around distribution of the workforce. So this is general practice doctors, family practice doctors across the UK by distribution of population. And Scotland's quite rural, a lot of it's quite rural. So, you know, there's never been a particularly strong concentration of doctors there. But you can see areas that, so right at the east of the country, at the top of the bit that comes out, that's Norfolk, and that's our fastest aging population in the UK. And as you can see, it's not exactly oversupplied with general practice or family practice doctors. And we think in the next 20 or 30 years, that's going to cause significant problems. That's a system that's already under strain. So our current major issues, as I see them anyway, so we have a lot of challenges that reflect the worldwide global issues around workforce, but some that are more specific to the UK and some I think that are due really to government policy. So we have a policy of austerity, retention. We actually have a retention crisis in the UK rather than a general workforce crisis, I think. And a lot of effort goes into supply. So increasing the amount of people going to medical and nursing and therapy schools, but we don't have the capacity to train them because they're vocational courses and they rely on an existing workforce. We've got lots of issues around not addressing retention issues, some of the ones that I've spoken about, some of the ones around pay, working conditions, basic workforce hygiene factors actually quite a lot of the time, work-life balance. The average unpaid overtime in our data set is around 10 hours a week that people are expected to work for free. So, you know, we've got a number of issues around retention. And also, as a country, across the UK, we pay virtually no attention to returners policy. So obviously, being a predominantly female workforce, we have a lot of mid-career leavers, but very little effort goes back into attracting those people back. So if the 3 R's of workforce, we pay a lot of attention to one, little bit of attention to the one in the middle, but virtually none on returners. A lot of our work-based workforce policy is not evidence-based. It's more politically influenced because it is a nationalised service, I think. So there's a lot of focus on activity, getting more work done, but not necessarily on the focus on the quality of work. And that leads to perhaps issues around patient safety. And then we've got changes to legislation. Yesterday, a bill went through the House of Lords, which looks at curtailing workers' rights to withdraw labour, so the ability to strike, and prohibiting that in the public sector without minimum service levels. So I think that's going to have a profound impact on people's rights in terms of the labour market. We've also this week had a fairly substantial policy launched around immigration. So despite being very reliant on the global workforce, the earnings cap has been raised to get a work visa here. Now, health has been exempted from that, so it's beyond the salary most health workers would earn. However, there are now further restrictions on even lower paid workers bringing family into the UK, and I think that's going to have substantial effect on our supply of workers in the future. In healthcare in the UK, we do virtually no workforce impact assessment. So policy lands on the system, it lands on the workers. This is an example of a big investment in workforce in family practice, introduction of new roles into family practice. And when we looked at the workforce impact assessment on the existing workforce, and very few of them were consulted about bringing new roles in, bringing new ways of working in. And this is fairly common. So we don't have workforce impact assessments at all. At least I've never seen one done in terms of policy. And also the introduction of things like new technology. So this is technology that was introduced into nursing, primarily EHR and e-scheduling. And it didn't give productivity gains. And this is about 5 years apart, we've looked at these people. So they have hardware issues, poor connectivity. They're expected to use platforms that don't connect to the internet, that are problematic. And then what we see is that this actually being an exit trigger for them to leave. So we're just figuring out a bit of that data right now. So that's all from me. Thank you so much for your attention, and please do contact me if I can be of assistance. Thank you.
Thanks so much, Alison. Big round of applause of the virtual sort, so you may not be hearing it, but thank you so much for that. I'm going to move on maybe to our next speaker, just holding off on the the questions of clarification right now. I know we'll have an opportunity to get into things. I certainly have some questions of clarification. I'm dying to know what a Christmas tree model is. But for now, I'm going to turn to Marilee Nowgesic, who is the Chief Executive Officer of the Canadian Indigenous Nurses Association. Thank you so much, Marilee, for getting here to us. I know it was a bit of a journey for you this morning, and we're so happy to see that you're able to join us virtually. So, Marilee, I'll turn it to you for a 10-minute overview of the situation in Canada.
Thank you very much, Steve, and my apologies to everyone. Of course, the intentions are well. When you leave bright and early, you get into the midst of traffic, and all of a sudden you see low tire pressure, and then you hear poof, you know, that your tire has now blown. So I'm driving into Ottawa, and you have to cross a bus lane that it is legal, and somehow get my car over to the other side of the road so I can be handicapped on the road in the middle of traffic. Anyways, I'm just so glad that I was able to get someone to come and get me, turn around, get back home here, and be with you. I just want to say good morning to everyone from here, where I am in the unceded territory of the Algonquin Anishinaabe people of what is known to the settler communities as Ottawa in the National Capital Region of Canada. I also extend wishes to everyone to join us in this session as I call upon my ancestors whom have brought me here to be with you today to be a part of this segment. I want to acknowledge Steve and the members of his team, and to Dr. Ivy Bourgeau for bringing me forward to discuss this very important topic with you. And on behalf of all my relations in Canada, Chimigwech. With that in mind, as Steve said, I'm the Chief Executive Officer with the Canadian Indigenous Nurses Association. We are the longest standing Indigenous health organization in the country and are approaching our 50th year in 2025. I should note, though, that prior to 1960, we were not recognized as an entity noteworthy of having an organization, anyone of Indigenous ancestry in Canada prior to 1960. Furthermore, nurses could not even apply to the faculties, to the schools of nursing prior to that time, unless they disenfranchised. So unless they took themselves off of the reserve list. That has now, that situation now has started to change, I should say, but it is a very complex picture, and it is a very complex map of how we look at the Indigenous health workforce in Canada. With that in mind, I'd like to just bring you into what it is that CINA actually is doing. We are the voice for First Nations, Inuit, and Métis people in Canada. With that said, we are now looking at how we are going to utilize identifier approaches in being able to address the complement that we need in the current health workforce situation. As many of you may be aware, media has its own spin on how they see things and how that message is being addressed to the rest of the country and, of course, to the people around the world. With that, we are now faced with another problem, and that is one that has culminated in some of the lowering, if I can say that, of the numbers that we see in the current health workforce situation. And that is because, unfortunately, racism is alive and well. We have seen the nursing workforce being attacked in this particular arena through the Indigenous population. We have seen many numbers change. And why, you say? People are afraid not only in the schools of nursing, but in their workplace because of the fear of harassment, hate, violence, and the list goes on. However, we, as of 2019, have done a survey across Canada looking at what those numbers might actually be for those people who chose to and can attest to their identity in Canada. We have now known that we're at least 12,000 people, 12,000 Indigenous, so that's First Nations, Inuit, or Métis, nurses across the country. That does not include LPNs, RPNs, PSWs, other categories within the nurses. This was specifically for registered nurses. With that in mind, we also are looking at other categories: the nurse practitioners, nurse management, and nurse executive leadership. And there seems to be, again, a hesitancy that we're seeing. Of course, when we're looking at these structures, we also have to look, we have a very dynamic and very complex, like I said in the beginning, a complex governance structure. We are representing First Nations, Inuit, and Métis nurses across the country, but we are also responsible to reporting to our Indigenous leadership. That is, for First Nations, the Assembly of First Nations. For the Inuit, way up north in Canada, the Inuit Tapiriit Kanatami, otherwise known as ITK. For the Métis population, the Métis National Council of Canada. So it goes from coast to coast to coast. With those numbers in mind, we are roughly over 1.4 million Indigenous people in the country. Yet we, as the healthcare workforce, make a very small number in that population, 0.0004%. One of my data analysts was able to tell me. And I'm like, that's unbelievable. No wonder why our health outcomes are the way they are. And it's no wonder why we saw a large departure in 2020 during COVID. Our nurses were overwhelmed. Our ones who were working at the band or the Indian Reserve levels were confined to those limited surroundings. They could not leave. They were working 24/7 with limited resources. So why then the departure? It's not hard to figure out. With that, we also saw we also have a large government structure for the Canadian government. With that, we work with our federal partners, and then, only then, do we work with our provincial and territorial partners. So when you're looking at everything from BC to Nova Scotia up to Nunavut territory, and then we look at that. And you say, why? Because we are a federal obligation, and then we have a secondary obligation to working with the provincial governments. One of the problems that we have in the health workforce sector is the identifier situation, which I alluded to earlier. And that has become a problem because you may have seen, unfortunately, in the media and people like Buffy St. Marie, people coming forward, and they're not coming forward. They're being flogged in public to their identity as pretendians, as false identifiers. So we're getting a lot of flack really in our health workforce about people whom are, I don't want to identify. I might lose my job. They only point out that I'm only here because I'm an Indian. And that's the reason I got my job. I shouldn't feel so entitled. And the list goes on and on and on. But with that, we have seen what those identifier numbers are going to do in the long-term process. We are closely working with the Government of Canada and looking at a health work for labor force analysis in regards to specifically Indigenous healthcare providers across the country. We know that they have them for the mainstream elements. When we click on the occupation classification code for nurse, it unfolds to 119 different subtitles. I was just flogged. They have numbers for them, but not for the Indigenous workforce. I'll figure it out eventually. We will get to it. The verification of identity is more, a little bit easier when we're looking at the people who live within an Indian reserve, because those band employed nurses are reporting to the chief and council that go through that process. However, I should point out that band employed nurses are not unionized. So there is always a constant turnaround of how, if a new chief and council gets in, they want to bring in a whole new ship of people. Unfair, but we're looking at how that's going to get done. Then we have those who work in government, private sector, or other entities, and how they're being protected in their workplace. When we looked at 2020 and we saw the droves of people that were being leaving the workforce, leaving the nursing workforce, we also saw the corporate nurses, the old guard, coming back in and saying, you guys didn't get your PPE lessons correctly. we're bringing back in the old guard to the nursing platform so that they can help generate some of the traditional practice, the old guard notification. We're also bringing back some of the clinical practices that need to be part of the change. One of the things that we have fortunately here in Canada is that we have the benefit of working with our settlers. And that's the most polite way that I can put it. I don't want to put any other labels on it. With our settlers and our allies, to working with them is through the Truth and Reconciliation Commission's calls to action. There are 94. In those 94, there are roughly 15 which apply to healthcare. And that's the ones that we as Indigenous leaders in this healthcare platform are working with our allies to try to address, to changing the curriculum in the nursing schools, the medical faculties, the midwifery programs, and so on, so that it reflects the actual Indigenous need and how we're looking at traditional practice and how that becomes part of that very much needed workforce skills and practice and training, your continuous professional learning. Where organizations have made a commitment to work with Indigenous groups, peoples, or other associations, we are looking at what is that commitment? How long does it last? When's the last time you wrote a 500-year work plan? Yes, I did say 500-year work plan. In my generation, we look for 7 generations beyond mine. If each generation is approximately 75 years, I'm writing a work plan that lasts for 500 years. That's the interesting part that we have when we're looking at Indigenous health workforce in Canada. I know that my time is now up. I thank you for this opportunity. I look forward to your questions and to our continued
so much, Marilee.
discussion.
Honestly, you have challenged us to think about a 500-year work plan. I hope that comes up in some of the comments later on. What does that even look like? Thank you, Marilee. That was wonderful. I'm going to turn now to. I realize I'm not giving us time yet for the questions of clarification, but I do think it may be helpful to move through the opening remarks and then to open it up to questions from people who are online and who are in the room. I'll turn now to Ruth Kearon, who is the Director of Health Workforce Planning in the Department of Health, Tasmania, the UK. Thanks so much for joining us at this ungodly hour, Ruth, and we'll turn it over to you.
Great. Thank you very much for having me along today to provide some opening remarks about the Australian health workforce context. I think you can see from the map that I'm coming to you from Nipaluna, Hobart in Lutruwita, Tasmania. And I pay my respects to the traditional and original owners of this land, who are the Mawinana people, and acknowledge today's Tasmanian Aboriginal people who are custodians of this land. Today I'm going to briefly introduce Australia's health system governance arrangements, because that leads to quite a number of our health workforce issues, and provide a high-level overview of the OECD indicators for Australia, an outline of our health workforce challenges before moving on to an outline of some of the work we have underway here in Australia, and I'll be happy to take some questions on it later. So we have a federated system in Australia. So we have the Australian government, state and territory governments, and also local governments sharing responsibility for running our health system. Underpinning our health system is Medicare, which is our universal healthcare scheme, and been in place since 1984 with various amendments and enhancements over time. But it basically guarantees all Australians and some overseas visitors access to a wide range of health and hospital services at low or no cost. It includes the pharmaceutical benefits scheme, which is related to our medicines scheme, Medicare benefits schedule, and public hospital services. And we also have a pretty large private health system operating alongside our public system. To support all of that, we need a health system architecture, of course, that reflects that, federated structure and the need for really deep engagement to progress with reform initiatives in health and other areas, of course. So it includes a fairly newly formed health workforce task force, which has reflected really the priority that governments are applying to health workforce at the moment in Australia. And then that reports up through various forums. So our Health Chief Executive Forums, which has our kind of senior bureaucrats in health across each of our jurisdictions, into the Health Ministers meeting, and National Cabinet, which just met 2 days ago and announced a range of new funding and initiatives in health. Look, I'm not going to dwell on this slide of the OECD highlights, but essentially we spend more on health per capita than the OECD average, and we have a higher than average number of practicing doctors and nurses per 1,000 population, but less hospital beds. And as I said, all the population is covered for a core set of services. We note that the patient out-of-pocket spending was lower than the average, but we certainly have seen that grow, and we have certainly seen our out-of-pocket expenses creating inequities in access to care. I thought I might just highlight our health workforce growth. So this slide is just looking at the full-time equivalent per 100,000 and percentage change. So really it's demonstrating the growth over and above our population growth in Australia. And you can see actually that we've had pretty strong growth, especially during those COVID years, 20 to 22. And the strongest growth in the workforce has been in a number of our allied health professions. We've got a couple of kind of major reforms in Australia, which I think are potentially driving some of that growth. And one is our National Disability Insurance Scheme, which is a kind of great universal disability coverage scheme, but it's certainly been created, I guess, shifts in the health workforce as we've kind of built a structure to support that NDIS service. And I think certainly the growth in the allied healthcare services has been predominant in our private sector, which is the sector which is supporting the services being provided in that stream. Interestingly, I think, and I'm not sure if other jurisdictions reflect this, but at the same time that we've had really significant growth, we also have really not felt so much deficit. And I really think that, we've got a range of health workforce challenges that I think have been magnified through those COVID years. And we're now really recognising that our health workforce structure and functions really not transformed over time to enable the delivery of healthcare that meets those emerging needs of the community. We have health workforce shortages being experienced right across our health services where we haven't had them before, even in some of our more metropolitan areas. Our education and training pipelines are governed by different parts of the healthcare system and different parts of those government structures. And really that creates this disconnection between the workforce needs of the system and the health workforce that's being educated and trained. That's a really kind of difficult problem for us to crack. Our international health professional migration and regulatory pathways are inhibiting the ability to attract and recruit IHPs in a timely and cost-effective way. And like others, we're certainly seeing a real uplift and uptick in the international health professional recruitment into the system. We've got a loss of generalist skills across the workforce. So I'm interested, Alison, in that your comments around the changing professionalism and how these two kind of conversations join together. But we can certainly see that our general practitioner, general practice specialists and our generalist physicians and surgeons are growing at a much lower rate than our subspecialty clinicians. Certainly mental health, wellbeing and workplace culture continue to impact on workforce retention, and we need to apply ongoing and constant attention to build our First Nations health workforce and improve cultural safety across the system. So it's planning here in Australia. So we've got a national medical workforce plan that was released a couple of years ago now, almost a couple of years ago, and that's really in an implementation phase. But we're also in various stages of developing national nursing strategies, national midwifery strategies, and national allied health professional strategy. You can see the stream of these are all kind of single profession focused strategies. And also state and territories, as jurisdictions who've got responsibilities to deliver health services, also undertake their own workforce planning processes. We've had a big review. It's called the Cook Review after the independent reviewer, but that's really been around designed to ease health profession skill shortages by removing unnecessary barriers and reducing cost, time and complexity of regulatory processes. We have also across the country got a scope of practice review underway, which is cross-professional in the primary care space, looking at how we best remove barriers to enable health workforce to work. And we've also got some work underway looking at how we understand the drivers for locum usage in Australia and opportunities for reform in that space. And finally, I'll just point to a plan that I've led here in our Department of Health in Tasmania. Just to note, we got these different layers of health planning reflecting our different responsibilities. And that plan really is focusing on 6 focus areas around making sure that we're building a workforce with people with the skills that they need and that they're geographically working in the areas that the community needs them. Looking at contemporary education and training pipelines, fostering innovation, leadership and culture development. We've got a very strong focus on that at the moment in our health system here in Tasmania. Making sure that our recruitment and working arrangements build our capacity to recruit, but really focusing in on how do we retain the workforce, so how do we decrease that churn, and making sure we've got planning capacity and capability. So thank you, Steve. I will leave it there for now, but as I said, happy to take questions later.
Thanks so much, Ruth. That was fantastic. And thank you again for joining us at this hour from your side of the planet. We're going to wrap up here with Dr. Erin Frerer, who is professor at the Department of Family Medicine, University of North Carolina, and director of Carolina Health Workforce Research Center. We had wanted to finish with Erin partially. Well, we're going to get the lay of the land from the US, but also Erin is in her remarks going to kind of try to tie into some of the other sessions that will happen at the conference over the next day and a half. Erin, please go ahead.
Wonderful. Thanks, Steve. Thanks, conference planners. So appreciated, Ivy. The Commonwealth has spoken. So now we will move to the United States. It's a pleasure to be here. I'm one person representing a very diverse country. I'll do my best. I was asked to be spicy. I will definitely try to be spicy. And we have 10 minutes, so I've got 10 factors shaping the healthcare workforce, and here we go. So our first factor that we're going to look at, and listen, we're way behind you all, is in the US, we are seeing an increased focus on addressing social risk and health disparities. You know, you all are familiar with this chart, which really shows, you know, we're now spending in the United States 18% of GDP on healthcare, and our outcomes are nowhere near as good as everyone else's. In fact, that's in part related to we spend a lot on medical care, much less on social care. So addressing those upstream factors, food insecurity, housing, it's been something that has been a more recent focus in the United States. And in fact, we saw life expectancy decline. The latest data from the Centers for Disease Control in the US suggests it has come back up. But listen, to Marilee's point, significant health disparities remain. So here in the United States, Native Americans and Alaska Native peoples were absolutely devastated by COVID, losing 6 years of life expectancy just in the COVID period. They regained 2.3 years of those life expectancy, but they remain below other. And it also for our African American population. So health disparities remain a focus. Number 2, you cannot open a newspaper or listen to the TV in the United States without hearing about primary care access and workforce shortages. And certainly this is a contributing factor to our lower life expectancy. You all spend in these other countries a lot more on primary care. The infrastructure of primary care is much better developed. We're trying to move there in the United States with some payment reforms, but we're facing significant primary care workforce shortages and generalist shortages that are really reducing people's access to care. Long wait times. Talk to any American about trying to get an appointment with a primary care physician right now, and you'll hear stories of long wait times. You know, and then everyone says, will nurse practitioners and physician associates save the day? And in fact, you know, if you look at the data, primary care physician visits are decreasing in the United States and have been decreasing. And we're adding about 30,000 nurse practitioners every year to the workforce. And NP scope of practice has expanded in 27 states to full scope. And so they can do diagnosis, treatment. And there's been a great study recently. The net effect is that the proportion of visits, mainly primary care visits, delivered by either an NP or PA has increased up to about a quarter of all visits right now in the United States. Those are mostly primary care visits, and they're for things like a range of eye disorders, hypertension, the kinds of things that we see in primary care. So this is a big issue in the United States, sort of around whether NPs, NPAs will be able to step in, particularly for primary care. But listen, integrating primary care, mental health, substance abuse, and social care has been another focus of the United States recently, and really has changed, I would say, the narrative around the kinds of healthcare workers that we need. To Ruth's point, you know, are we configuring the workforce the way that we need it to produce health? And so we're sort of looking at a broader range of healthcare workers than have typically been considered in the health workforce. So everyone from social workers, pharmacists, community health workers. And it's interesting if you look, you know, in the United States, our payment policy is a really interesting way to track what's happening in the United States. And our Centers for Medicare and Medicaid Services, which fund our federal program, we do not have, as you know, universal health insurance. We do have health insurance for people over the age of 65 and people from low income. But CMS has really been focused on expanding the types of providers and services that can be reimbursed. So looking at things like, how do we pay for community health integration, illness navigation, better pay for mental health and substance abuse treatment? So suddenly we're not just paying for these services, we're expanding the types of providers who can bill for these services. So now looking at allowing our social workers, our marriage and family therapists, peer counselors, and others either are currently able to bill or soon will be able to be billing for services. So, you know, in the United States, you keep your eye on the money, and this is telling you where the focus is. You know, I think each of our speakers has spoken to this, and that's one of the things I have always loved about the IHWC is, you know, different systems, similar problems. Burnout and moral distress are absolutely rampant. Our health workforce in the United States is increasingly unionizing and striking. CDC just put out new data on our health workforce mental health crisis. And you can see these reports that are coming out regularly about healthcare workforce and workers experience anxiety, feeling absolutely overwhelmed with workload, feeling powerless, absolutely powerless to affect their working conditions, and are not going to recommend this career path. And in fact, you know, we saw our nurses striking in New York City at Mount Sinai. This was a big deal in the United States. We're seeing increased collective action happening. And in fact, there was a great New York Times article very recently talking about why doctors and pharmacists are in revolt. And it really interesting if you put your lens, if you put your hat on, as sort of thinking about doctors being not ones that you would think of unionizing, are now moving more towards being salaried and employed labor, and are feeling very much put upon and powerless. And one of the things we see, this is some work that we did with Andy Napton from the UK, where we were projecting the supply of the nursing workforce. We did this work prior to COVID. And then we did this cool thing called backcasting, where we compared our forecast of supply to the actual numbers that came out. And so what you're looking at is that analysis, where the blue line is the actual supply of nurses, and those other lines, that sort of orangey line, the yellow line, the gray line, are what we would have projected would have been our nursing supply under different scenarios. And one of the things that you see consistently is that our actual supply in North Carolina in 2022, this was a study we did in North Carolina specifically, is significantly below what we would have projected based on historical trends for that middle-aged workforce. So we are saying it's really, you know, it's those early to mid-career RNs who are missing from the workforce. And that really gets to these issues around returner policy. What are we doing to attract these people back to the healthcare workforce and to nursing? And I'm sure we're seeing this in other healthcare workers. We're just modeling it right now for nurses. So will this be permanent, or is it temporary? How do we attract these workers back? Interestingly, you see our scenarios were a nice match for people over the age of 50 when it's too late to retire or too late to change your career. So we feel pretty good about the modeling itself. Similar to what Ruth was really reflecting on, our training investments in the United States are not well aligned with population health needs, but there is hope. So I always like to put this out there. Medicare, our funder, is the main funder of graduate medical education for physicians, resident or registrar funding. $16 billion 16 billion annually. Most of these funds go to hospitals in urban areas, and there's been absolutely no change in how Medicare GME funds are allocated due to resistance from numerous stakeholders. And Medicare funds are capped, right? So you can't change the current allocation. You have to put new money out there. And we did see new money come out. And it's interesting when you look at where that new money was targeted. It was targeted towards trying to address those maldistribution issues. And when I say maldistribution, I mean by geography, I mean by specialty, and I also mean by setting. Care's moving from hospitals to outpatient community health settings. How do we get training there? And the Health Resources and Services Administration stepped in and has been investing $54 million to start new rural residencies and needed specialties in rural areas, and another $175 million, if you know about our Teaching Health Center graduate medical education program, is mainly based in community health centers, outpatient settings. And then interestingly, folks, they invested $46 million in this teaching health center planning and development program. And this was to help places that really wanted to start training, but didn't have the capacity. And states are not waiting for the feds to move. They are investing in training and in really up in the billions now of dollars to try to address population health needs. The eighth thing that we're tracking is telehealth. And this chart is showing you the share of outpatient visits delivered by telehealth. That blue line is other outpatient visits. That top line is telehealth visits for mental health and substance use disorders. I love this chart. It's a little old, but I love this chart because what it shows is what we all experienced, at least in the United States, is this bump up in telehealth during COVID. And then this decline, and now at least in most outpatient primary care practices have moved back to in-person visits. But mental health and substance abuse visits are still being at a much higher rate being seen through telehealth. Now that number might be down to about 30% now, but it's still significantly higher. So behavioral health may have some staying power in terms of telehealth visits going forward. So we'll see how that plays out. And meanwhile, we're all sitting here waiting for, what is going to be the role and impact of artificial intelligence on the healthcare workforce, right? Is AI a threat to jobs? Will it replace jobs? Or is it a way to eliminate burdensome tasks, produce better patient outcomes, reduce burnout? Our Health Workforce Research Center at the University of Washington, I'm going to give you their information in a minute, is doing a report, a study right now to sort of begin to understand these things within the allied health workforce. So keep your eye out for that report. The ninth thing in the United States is we're seeing an absolute politicalization of healthcare. The effect of Dobbs, which was our Supreme Court decision that the Constitution did not protect the right to abortion, has had significant knock-on effects on reproductive health and access. One Idaho hospital completely stopped obstetric care services, citing doc shortages, fewer births, and a political climate that criminalized physicians from medical care nationally recognized as the standard of care. And that same press release noted that highly respected, talented physicians are leaving and recruiting replacements will be extraordinarily difficult. And so at the same time, we have folks tracking what is going to be the implications for training. And nearly 60% of medical students in one study reported they were unlikely to choose a state for training with abortion restrictions. And the implications for our existing workforce are significant. So abortion-related paperwork, counseling requirements are going through the roof and could lead to increased burnout. So in my own state of North Carolina, abortion patients must hear and initial some 20 consent statements. And these things are not just related. The politicalization is not just limited to reproductive health. We saw it during COVID vaccine rollout. We have issues right now, huge issues around gender affirming care and many other examples in the United States. And the 10th thing that I just want to highlight is in the US, we're seeing very much an increased corporatization of healthcare, right? So our healthcare systems are facing increased competition from corporate players, private equity, who are redesigning the workforce, care delivery models, and using technology to deliver care. And you're seeing corporate giants buying up primary care practices. Why? Because these primary care practices are going to be the conduit for referrals, right, which generate more income. I don't know if you saw, Amazon has announced its new benefit for Prime members for primary care for $9 a month. This is like a classic example of what's happening in the United States. And there's a wonderful New England Journal of Medicine paper, very recent paper that talks about why this is happening and the potential profits, pitfalls, and progress that could be happening. But one of the things it really highlights is something I reflected on earlier, is really reducing physicians' sense of sort of clinical involvement and clinical judgment. So those are the trends from the United States. I just want to highlight, I'm so lucky to be one of the 9 federally funded health workforce research centers. We are grateful to our federal government that funds us to conduct research and generate data to really shape health workforce policy. These sister centers are remarkable, doing remarkable work in emerging health workforce topics, oral health, long-term care, behavioral health workforce, health equity, allied health, and public health. So if you want to know more information, there are many people who will be attending this conference who can help you. And thank you very much. I look forward to the discussion.
Thanks so much, Erin. Wow. That was fantastic. Erin, I don't know that I have ever seen you speak in a way that wasn't perfectly spiced. So thank you so much for that. Thank you to all of our speakers. Fantastic, really just fantastic opening remarks. I think giving us a unique window on each of your countries in a way that we don't get that. And so you've delivered that so wonderfully this morning. I want to turn it, there's a number of ways we could go forward here. I have some questions of my own. I want to defer instead to people who are online and people who are in the room this morning first, maybe just to get as much as you can. I think we've got about 300 people online here today. So I don't know how we can be fully engaging, but maybe what I could do, Sheena has a view on the chat. Sheena, I'm going to give you a moment just to maybe scan that chat and look for a question that maybe summarizes some of what you're seeing on the chat, if there's stuff there. And in the meantime, I'm going to turn to the room here and just see if we have a question in the room while Sheena does that scanning of the chat. Margaret, please.
Thank you so much to all the presenters. That was really fascinating. I just have a question for Alison. Leary, I wonder if you could comment on, you mentioned the recent immigration reforms in the UK and the fact that the salary cap, there's an exemption in place for healthcare workers. I wonder if you can give me your opinion on what you think it says. I mean, personally, I think it says that the UK government is not really interested in domestic recruitment, if that's how they're viewing the sector. But I wonder if you have some thoughts from responses as well to that immigration policy change.
Yeah, I mean, I think it sends the message that they're looking for short-term immigration solutions. So young people coming for a couple of years to get to bolster the workforce, but not really staying and becoming part of the community. I think that the cap is like 38k, which excludes most of the, about 43% of the workforce, at least, actually. It isn't around where we also have shortages. So I think it also excludes social care, where we obviously have a massive deficit. So for me, I think there is an issue around value of those workers, but that's something that I think is very long-standing in terms of the pay scales generally, and the nationally negotiated pay.
Thank you for the question and for the response, Alison. I have to say this question of internationally educated health workers and any sort of shift that we've seen post-COVID is one that came up in the discussion with the panelists when we were preparing for this session. I want to give it, I know there's other questions in the room here, but I just want, will you ask, Ivy? Wonderful, thank you.
Yes, thank you. So there are three questions that have come in. I'm going to ask them and then you guys can decide what question that you want to answer. So first question that has come in is just any perspective that you have on oral healthcare providers, shortages in your countries, dentists, dental hygienists, dental therapists, etc. And also sort of what has been what has been the most promise shown around retention? This one specifically directed to you, Alison, but I think others can focus on retention, as you noted, attrition, workforce attrition being, a particularly important issue. And if all of you can kind of address like the invisible issue of return, right? So that's the other side. And then the third question is looking at recalibration of the workforce, this greater shift into community primary care as opposed to acute care. How far is that going? So oral care providers, retention, return, and recalibration. I'll pass it over to you.
Sure. Yeah. So oral care is a really substantial issue in the UK. Our primary oral care is provided by contracted private providers contracted to provide NHS services. Because of the reimbursement programme, many are choosing not to provide NHS services at all. We have seen a rise in something which is horrifically called DIY dentistry. And also the incidence of children needing oral surgery because of poor dentition and poor oral care. So it's actually a public health issue, I think. Recruitment and retention. Retention is it's kind of the usual thing you would expect: pay, but also flexible working. Flexible working is a big retention factor, true flexible working. So where we see people being able to apply things like annualized hours, flexible rostering, we see better retention. And that's reflective of the workforce generally. In returners programs are pretty rare in most of the countries that we've ever worked with. But where we see this in other industries, structured returners programs, structured paid returners programs, so not internships, actually get people, particularly women, back into the workforce at mid-level. So are actually shown to be beneficial in areas like IT, engineering, those sorts of sectors. And the last one is we've primarily had a community-based service in the UK for about 200 years. So that shift, most of our care is actually provided in the community rather than in acute hospitals. In fact, we have one of the lowest hospital bed bases in the world, as I understand it.
Oh, thank you, Alison. I am wondering, just this question of the circumstances of work, if I could maybe, I don't want to put anybody on the spot panel-wise, but Marilee, if I could, I know that in our preparatory conversation, this issue of the circumstances of work really came up, in this idea of sort of being trapped in your job, kind of a regulatory sort of chains that you had. I wondered if you wanted to just do a quick reflection. I will turn it over to also Ruth and Aaron to maybe do a bit of a response to those three questions if anything comes to mind. But Marilee, I wonder.
Not a problem, Steve. So thanks for that. So in regards to what that's really looking like in Canada, it is such a mishmash of what do we do? And I think, getting to some of the comments into just how do you shake the box without losing all the important parts that you need? And that's, I think, what becomes part of the overwhelming, sometimes disheartening, because we're seeing the removal of people in some healthcare environments that are essential. I wish I could say I had some of those numbers that my colleagues have mentioned on this call with increases. If I could have 30,000 nurse practitioners in Canada, the situation for Indigenous health outcomes might be better. When we're looking at how we're trying to work within those regulatory, and I have to be very careful with that term, because a lot of the Indigenous nurses working at the community level have to think outside the box, because you have to be innovative, ingenious, and willing to take that other traditional approach, blending your Western medicine and your Indigenous world into your profession without crossing the line. Thanks, Steve.
Thank you so much. It's so interesting to hear these, unique sort of circumstances within countries. Ruth and Aaron, I wonder if I could turn to you maybe if you have some reflections on.
I might just make a comment perhaps on the oral healthcare providers. We do have it's almost like an anomaly in our Medicare system in that the teeth are not considered to be part of the body. So dental services are not considered in the same way as a whole range of other healthcare services. But we do, of course, have some public dental services for people who are eligible for those services, but on the whole, it's very much run in our private part of our healthcare system, which really means that there is significant inequities in access to care and significant cost inhibitors for accessing care for some parts of the community. So I think that's probably one of our key kind of issues in the oral healthcare space. In particular, at the moment with increasing cost of living pressures, which, are decreasing the accessibility of some of those types of services. So, that's just a kind of an interesting kind of part of our system here in Australia. In relation to the return to work, I would agree, Alison, I think we have less focus on that area. We certainly do have, in the jurisdiction where I am now, some very targeted return to work programs for, in particular, our nursing staff. But they are, it's kind of not really entrenched part of the system. It's a bit more of a niche program. So, I guess, it's how do you move it from that kind of niche program for a small number of people into being, I guess, a more broadly available and known about option for people to be supported back into the system. I might just leave it there for now. But Erin.
Sure, I'd be happy to jump in. So one of the things, I'm speaking from a perspective of being a researcher, of course, but we do find that data and modeling are a good way to change the narrative. So in our nursing model, really showing policymakers, because when you go to policymakers with a problem around a shortage, their immediate instinct is, let's build a new school, let's put more into the pipeline. And it's really helpful to show them, using modeling, the fact that that's only going to increase your supply very incrementally, and that the real bang for the buck is on that retention piece, right? So I am a believer in data and modeling to change narratives, and we've been working really hard to kind of have taglines. We're not going to educate our way out of this shortage. It really is about returners. And as we're talking about returners and using the data that I just showed you to show those gaps, we really need to be thinking about how do you design returner policy across the life course of a health career, right? So how you entice a younger person to return to the workforce may be, a structured onboarding, a promise of tuition reimbursement to be able to go on further education. It may be money versus how you might attract someone in the mid-career. So I just want to point out sort of having more structured, tailored approaches. And to Ruth's point, one of the things we're trying to do in the United States is really build the evidence around which of these retention policies work for which types of healthcare workers and which ages and genders, et cetera. So I think we're lacking the evidence, and I think that's one of the things coming up in this panel today. And just on oral health, we have a health workforce research center at the University of SUNY Albany, which is in New York, that focuses on oral health. It's really been looking at a lot of these issues around dental therapy, but also can we shift oral health training into communities where it's needing, because like medicine, it tends to be very focused. So those are just some of our thoughts about this.
And thank you, everyone, again. Maybe I'll go to the room now. I do see some hands up. I think I had seen Arthur first, and then we'll maybe come over here. Thank you. Oh, you have to, there's a little button on your mic. If you just click that up.
Okay, there we go. I think it's on. Thank you very much. Thank you for an extremely interesting panel. I really enjoyed it. So thank you to the four speakers. I wanted to follow up on the nursing shortage issue. And I want to give you my interpretation of what's happening in Ontario, because I have access to reasonably good data in Ontario from the regulatory colleges. So I'll give you my interpretation. I think, from what I can tell, that it's more or less the story in the rest of Canada. Of course, Canada doesn't have one healthcare system; it has arguably 13 healthcare systems. So it's hard to make any broad statements. So my sense, what's happening in nursing here, is that during and we're still ongoing COVID, demand for nurses clearly went up. And we have shortages, not because supply has gone down. Supply has been actually pretty stable, pretty consistent. It's really that demand has gone up. Especially, there's a backlog of surgeries and backlog of treatments that happened during COVID, and we're trying to catch up with those backlogs, et cetera. And also there's a lot of nurses who, especially in the early days of COVID, were taking long periods off because they were potentially contagious or were contagious. So that again drove up demand. So I think most of what we're seeing here is not about reductions in supply, but increases in demand causing shortages. And in terms of the turnover, we spent a lot of time looking at this. We have seen a lot, just enormous employer turnover. So a lot of churn, but actually we've seen very little occupational exit. And in fact, in the early days of COVID, nurses really stepped up. They delayed retirement quite a lot, and a lot of people who would normally have left stayed and worked. So I kudos to the people who, in some sense, delayed stopping work for a while to serve because they felt they really were needed. So we just don't see that occupational exit. We see a lot of churn, but not occupational exit. The one odd thing we're saying is that the regulatory college, every year when nurses register, they ask a question about what they obviously get questions on hours of work, but they ask an opinion question about whether nurses would prefer to be working full-time or part-time. And one of the things we have not seen, which we might have expected to see, is a fair number of nurses who are working part-time say they prefer to work full-time. And we're not seeing those nurses transit into full-time jobs. Like that in the short term, to deal with sort of like the COVID bump or the COVID trough, maybe I should call it instead of a bump, we would have expected a bunch of the part-time nurses who say they'd prefer full-time jobs to be moving into full-time jobs. And that just doesn't seem to be happening. And we really don't understand why. And so anyway, I just wanted to give the Ontario perspective and see if it resonated with you, the story I'm telling, if it resonated with the other countries, and how you're dealing with this full-time, part-time issue and trying to get the allocation right between the people who want full-time and some people prefer part-time, how you get that sort of the match between people's preferences in full-time, part-time, and what they can actually find in the labor market. Yeah, thank you.
Thank you, Arthur. I'm going to turn it, I think you're directing that sort of a bit of a reflection from the panel. Yeah. I don't know if, just would invite.
I can initially jump in here. Go ahead, Marilee.
I was just going to say, some of the from the Canada lens, some of those, Arthur, are based on the mandatory employer-related costs. If we're already in a system that has been depleted or has already been strapped as much as it can in regards to what's available as far as money's available, I'm thinking acronyms here, full-time employee or person year available for salaries. And employers are just saying, I can't do it for full time because then I've got to look at paying all of these other situations. Well, then what is your priority as an employer? Are you providing a service or are you just looking at your talent pool? And those become the real questions when we're looking at urban and rural situations. However, in Indigenous world, that's not really on our radar. So we look at alternative approaches to how to address that part-time, full-time situation. Thanks.
Yeah, and I'd just jump in here. I'm really intrigued by your notion that supply has remained stable because, in fact, we have the data. We have a full census of nurses, and we're not seeing a supply that is stable. In fact, we're seeing workforce exit, and so it's interesting that you're not. So I wonder if there's a data collection or something, some difference in the way that we're measuring workforce participation that could be contributing to that difference. But I'm really interested in Marilee's in this comment around part-time versus full-time work, because one of the things we are seeing is one of the ways to retain workers is scheduling flexibility, right? So certain workers want that scheduling flexibility and others would prefer to work full-time. So that is part of also what we're seeing is the growth of companies that are actually matchmaking between healthcare workers and healthcare employers to say, I want to work these times and whatever, and they're actually doing that match. I sort of think of it as the Uberization of the labor market. So we are seeing some of that mismatch as well.
Well, interesting comment, Uberization of the workforce. Isabel, please. Yeah, there's a little switch that you slide up, yeah, around there. You may have to turn the mic to see
Got
it.
it.
There you go.
Thank you so much. It's actually kind of in link with what Aaron and Arthur were mentioning, but in order to provide that flexibility in the scheduling and hopefully attract more people to go from being part-time or increasing their number of hours a week and hopefully having more full-time employees, telehealth might be one of the strategies, and it might increase access to care in rural areas and different parts of countries where we have less labor. However, speaking about dietetics, one of the barriers is that you have to be registered. So we're in Ontario and you have to be registered in your geographical area. So here it's a province. So if you want to provide care in other provinces, even through telehealth, you have to be registered at the College of Dietitians of the province where your clients are. So you could be in Ottawa, and if you want to provide services in Quebec and Ontario and in another province, as a health professional, you have to register to each of the separate colleges and pay all those fees. So that would be a barrier for health professionals to be providing access to care in other geographical areas. And this is an issue that I wonder if there are best practices out there, ways that we can improve that to increase access. Thank you.
Good. Thank you, Isabel. I wonder if panelists have thoughts about Ruth. I see you. Maybe.
I was just going to make a comment about the registration and regulation of healthcare workers. Certainly that was a reform that was undertaken in Australia about 13 years ago. We moved from having jurisdictional registration to having a national registration and accreditation scheme. But we still now do have those challenges of how do we even contemplate things like international service provision in the telehealth and virtual care environment. So increasingly in areas like radiology, pathology, and I presume increasingly into the future, we'll also need to grapple with how do we look at the transnational health service provision and the transnational workforces. So.
So do I understand that it applies to all the health care disciplines and social work disciplines, Ruth? Because this is amazing. This is the first time that I'm hearing about that, and I think that might be a best practice.
Scheme. Oh, sorry.
The question
so
is,
it's.
Oh, go ahead.
Oh, no, I was going to say, we don't have all of our health professions under the scheme at the moment. So there were a number that came in with the initial reforms, and we've gradually added paramedicine and their consideration of further professions into the future. But certainly it's not a full coverage. But for some of the other professions, allied health professions in particular, there are certainly mechanisms through their professional associations around registering with those bodies. Yeah, registration is not the right word, but yeah.
That's great to hear.
Congrats. It is fascinating. I think Australia, to my knowledge, is sort of light years ahead. I know certainly compared to Canada and perhaps to other countries as well in terms of centralizing that process of registering. I know that the question of regulation and sort of disciplinary action and so on is a different kind of thing, but the paperwork of it has been made so much easier for professions in Australia. I know that there's some questions online, and I'm going to turn back to Ivy, who may be able to reflect those online questions.
Great. And also just to note that our first session tomorrow morning will also be speaking about regulation. So Peter Brooks, a colleague from Australia, asked a question in regards to the loss of generalist skills that came up in the presentations, and asking whether the panelists think that this will increase low value care, because specialists, he said in Australia at least, tend to provide more low value care. So this issue around generalist skills, the loss of generalist skills, And then the second question from colleague André Garpi from Quebec is looking at government oversight entities that look at the fairness and efficiency of registration practices. And, you know, that's 9 provinces out of our 10, 3 territories. And Ruth, you've already mentioned that that's centralized, but this issue about fairness of registration practices and just wondering whether or not you have something similar in your countries. So those 2 questions, back to the panel.
I could take the regulatory one. So in the UK, our regulators have a regulator, the Professional Standards Authority, that sort of tries to look at the fairness and proportionality of regulation. Our government, however, wants to deregulate to a great degree many different professional groups. So it's a bit of a fine line at the moment, I think, in the UK.
I can also jump in on the deregulation issue. One need only look farther than Tennessee, where they are trying to change the regulation for who can become a physician and how they can become. So in the United States, you generally have to do a residency in the United States unless you're Canadian. They're trying to change it for international medical graduates to be able to practice as physicians for some time and then become fully licensed. So it's interesting to watch sort of as states in the United States sort of try to grapple with health workforce shortages by changing regulation. But Peter, I do want to address your generalist issue. I think for us, it's not only the proliferation of low value care in the United States, but those slides that I showed you on our primary care crisis is really leading to issues around the people not getting preventative care, right? So then having it crop up later as a bigger issue. And really, that's a huge loss in our system, as well as the fragmentation. If you're seeing a bunch of specialists and no one's coordinating your care, that's another big issue we're looking at. It also contributes to cost, right? Specialists are more expensive in our system in the United States than our generalists. And the last thing I would say is, you know, our primary care docs, if you look at the distribution, for example, of family medicine physicians, much better distributed geographic workforce and across settings than, say, some of our more specialized colleagues. So I think that the effects are actually multifactorial in terms of that loss of generalist skills, and is really one that we all need to be keeping our eye on.
I have to say, I will take the prerogative. I do think there is a very interesting sort of sub-narrative to all of this. And it came up in some of the comments that were made by the panelists. Alison, you talked about the taskification of health work. Aaron, you talked about, you know, sort of this shift from MDs doing primary care to nurse practitioners doing primary care. Ruth, you talked about this scope of practice review that's going on in Australia. And in Canada, we have this paradigm around competency-based education. We want, in a way, there's this incredible human proclivity to segment and to define and to then measure. As researchers, we are often measuring, and we were wanting to know, what is it that you do? What are the tasks and the things that you do? And there are good reasons for us to do that. To understand and to plan and to be able to work together as teams and so on. We want to know the specific things. And yet so much of what you are saying is about this adaptiveness. When you talk about sort of generalist expertise, Aaron, and when you talk about adaptiveness, I work for the College of Family Physicians of Canada, and we certainly talk about, you know, obstetrical deliveries, this, anesthesia care, that, but we also talk about adaptiveness as a thing in itself, as a skill that needs to be sort of nurtured in family physicians. So I do wonder, I want to put to our panelists the idea of how do we resolve this tension of wanting to be clear about what we do, or what others are doing, and yet still having this flexibility in the health workforce to allow one to adapt to the circumstances that they're in and to optimize their skill sets and so on. So I just want to put that out and wonder if the panelists have any reflections on this, sort of resolving the tension between the reductionism and the being flexible about adaptiveness.
If I could, Steve, I'll take that first. In the Indigenous platform, that's the name of the game every day. So our skill set has to be general. You have to be everything, because when you're looking at the limited environment that you're working with, if you're in a First Nation or an Inuit community, you're not a nurse from 9 to 5. You are a nurse 24/7. And when they find out where you live, they come right to your house as opposed to the clinic to see you. You know, my whatever hurts, this hurts, that hurts. And we have to look at that. I hate to put the label of generalist on it, because they're experts in their own approach because of the environment that they've been placed within. And unfortunately, the limited resources that they've been provided. So you have to make shift all the time. You have to think outside the box. If the nursing station is frozen the door, well, is there a window I can slide open and crawl in? Yes, we've had to do that too. So those types of things, I don't know how we can reduce the harm. We just have to think of what do we want to be able to do for our profession, for the people, so that they don't get stuck in the bureaucracy. Thank you.
Thank you, Marilee. I saw some heads nodding. I want to just turn it to the panel if there are other thoughts from the panel, maybe just reflecting on that.
Yeah, I think practice, the application of those knowledge, skills, competencies is less valued than the technical task accomplishment. And I think that's, that's the thing about the, healthcare is humans relating to other humans and practicing an art and a science. If we look at Dreyfus and Dreyfus, novice to expert, all of that kind of that work, I think in the UK, certainly we've suffered greatly from the introduction of new management theories in the 1980s that has made workforce more reductionist, industrial, like a process to try and measure it, try to increase its productivity. And I think a lot of the issues around praxis being lost are related to that. That's a personal opinion.
Thanks so much, Alison. Yeah, I think that reflects the tension there. I just want to turn it maybe to Ruth, and just noting the time too. We're down to our last few minutes here, so if you panelists want to say a little, we've got 3 minutes to go. And
well, look, Steve, I'll just make just a brief comment, and I think, as I kind of mentioned in my opening remarks, I think having this shift away from the generalist workforce into kind of increasingly kind of buckets of highly specialised care is not necessarily delivering us the workforce to deal with the issues that we have today around how do we manage chronic and complex illness in an ageing population. But at the same time, I don't see it as a polarity. We kind of need both. So, we are also living in an environment where we can do amazing things in healthcare. And there's some highly specialised areas that we want our health workforce to be working in with particular skills. So I kind of, I think we need both, but we can't lose our end game of making sure that we are creating and supporting a health workforce which can actually address the big problems that we have, which is in that chronic and complex and ageing population where we need people to be taking a whole of person view. So that's my kind of view, that it's not either or. We need both, but we need to make sure that we are kind of really putting our target where we know that the big gains can be made for the community.
Thank you, Ruth. You're reminding me of a theme that came across in a number of the comments, this idea of actually being responsive to local needs and community needs and so on. So how do you enable that? Aaron, I'm not sure if you wanted to take 30 seconds or something.
Yeah, 30 seconds. I think there's a difference between generalism and specialism, which is one theme we've talked about, but also what we think of as plasticity, which is the ability of a workforce to really flex depending on the needs of their patients and the needs of their community. And so I think that it's important to recognize that plasticity or that flexibility is a function of both the individual's practice patterns, but also the environment that they're put in. And what we're trying to do is create systems that promote that plasticity. And whether that's NPs and PAs in primary care, or it's in what I talked about in substance abuse, mental health, or wherever, I mean, that's fundamentally what we're trying to produce. And team-based models of care. And we'll set up that panel.
Thanks so much, Erin. That's wonderful. I wish we had more time. I know that we could use it. I do want to thank again our panelists today. What a fabulous opening session to this little mini conference. Last word I will say is we're going to log off now. I'm not quite sure how this works for others. You probably have to reconnect to another session shortly here. But we do plan to do a bit of a summary for this session. There were, from your comments today, there are overlapping things. There are things that are unique to each of your jurisdiction. At some point in time, we hope to get together a bit of a write-up of what was said today, both in terms of the panelists' comments and some of the questions that were put forward. So thank you again to everyone in the room, everyone online, and to our panelists.